CPR overview and a review of techniques. Chest compressions are the key part of CPR. American Heart's phrase now is push hard and fast in the center of the chest. Proper hand position is over the lower half of the sternum, above or superior to the xiphoid, and below or inferior to the nipple line. Full recoil of the chest is also very important. This is emphasized in the 2010 guidelines, and we'll certainly emphasize it in our training. Proper depth is important, but also allowing the chest to fully recoil is probably just as important. Proper chest compression rate is 100 per minute for all ages. It's not as fast as you can go, it's 100 per minute. Rates of 140, 150 and higher are not better. They don't allow for proper ventricular filling, and so the correct rate is 100 per minute. Some people find remembering the Bee Gees song Staying Alive helps them keep that rate correct. Proper chest depth is 1.5 inches for infants, which turns out to be about 1/3 of their chest depth or their anterior-posterior diameter. Proper depth for children is 2 inches, again also 1/3 of their chest depth. And 1/3 of the chest depth for adults is also appropriate, but because adults come in so many different sizes, the phrase at least 2 inches is also added. We should be careful to limit the interruptions in chest compressions and never to longer than 10 seconds. Blood flow clearly slows down and is slow to return with any interruption, and so we need to be careful during our switches and our airway management to limit those interruptions to no more than 10 seconds. So, in summary, with compressions, push hard and fast in the center of the chest to find us the lower half of the sternum, allow a full recoil, keep our rate at 100 for infants, children, and for adults, and let's keep the chest depth of the compression at about 1/3 for infants, for children, and for adults. The actual measurement turns out to be 1.5 inches for infants, 2 inches for children, and at least 2 inches for adults. And then do continuous compressions that are not interrupted for more than 10 seconds. In addition to chest compressions, we need to provide electrical therapy to patients in cardiac arrest. Adult patients, the most common rhythm that is seen in the initial seconds and minutes of cardiac arrest is a very disorganized electrical activity called ventricular fibrillation. This is a chaotic electrical rhythm. It is not producing any mechanical pumping activity. And so ventricular fibrillation, or a very rapid ventricular tachycardia, is called a shockable rhythm. Your automated external defibrillator, or AED, analyzes the rhythm for you, determines if it is a shockable rhythm or some other rhythm, and takes the appropriate action. If the AED determines that the rhythm is a shockable rhythm, the AED will choose the correct energy level and charge up. During the charging, you get audible and visual cues, and you get an audible and visual cue when the charge is complete and it's time for you to defibrillate. When you defibrillate, safety is paramount. We're suggesting that you keep your eyes on the patient. Once you've found the shock button on the AED and placed your finger over it, there's no longer a need to look at the AED. Look at your patient. In case a rescuer or a family member or someone else comes in contact with that patient, then you can hold the shock until it's safe. Use a simple script before you shock to improve our safety. Announce clear as loud as you can, and then say shocking on 3 and count 1, 2, shock. As you say shock, then you would push the shock button as long as the patient is still clear and it's safe to defibrillate. American Heart's 2010 guidelines emphasize that defibrillation for infants and children is appropriate in the case where they have a shockable rhythm. Our AEDs have pediatric pads, and you can use those on the anterior and posterior if needed, if there's not enough room for the standard pad placement. We're going to turn now to talk about ventilations, and we're going to talk about proper pressure, proper depth or volume of ventilation, and then the proper rate. Good, smooth, low-pressure breath is a key to limiting gastric distension. You want to avoid a chaotic, rapid squeeze that produces high pressures and forces air into the stomach. Proper volume of the ventilation is the next most important thing. We just need a normal chest rise. We don't need a maximum chest rise. We need to provide a ventilation volume that gives us a normal chest rise. Anything over that will produce air in the stomach, gastric distension, and the associated problems. The rate of ventilations is usually determined by the ratio of compressions to ventilations, which we'll cover next. But in the cases where there's not compressions being performed, then rescue breaths, or ventilations only, should be done at the rate of about 1 every 5 to 6 seconds, or count to 5 and squeeze for adults, and then a little bit faster than that, every 3 to 5 seconds, or count to 3 and squeeze for children and infants. The ratio of compressions to ventilations is sometimes confusing. I'm going to try to give you a couple of straightforward rules. If you're doing adult CPR, your ratio is always 30 compressions to 2 ventilations. Whether you're doing 1 rescuer or 2 rescuer CPR, adults always get 30 to 2. 1 rescuer CPR ratio is always 30 to 2, regardless of whether it's an infant, a child, or an adult. If you're by yourself, it's 30 to 2. In the case where you're doing 2 rescuer CPR with an infant or a child, then the proper ratio is 15 to 2. So in review, adults are always 30 to 2. If you're by yourself, it's always 30 to 2. But if there's 2 rescuer CPR for an infant or a child, then you should switch to 15 to 2. 2010 guidelines emphasized that once an advanced airway is in place, compression should be continuous. An advanced airway, according to American Heart, is an ET tube or a combi tube. And once one of those is in place, then compressions can be continuous. There's no more ratio. And a breath is given every 6 to 8 seconds for infants, for children, or for adults. Cardiac arrest management happens in a series of 2-minute drills. The best way for us to know that 2 minutes have passed is when 5 cycles of 30 compressions to 2 breaths, so 1 cycle is 30 compressions and 2 breaths. When you've done 5 cycles of that, then 2 minutes have passed. After 2 minutes, it's time to analyze the rhythm. This is also the same sort of pattern that the ALS crew will use when they arrive. Also, during the rhythm check at the 2-minute mark is an excellent time for us to switch compressors. We know that your best CPR is your first minute or 2 of CPR, and so we should switch compressors after 2 minutes whenever possible. Here's a chart of rate, depth, ratio, rescue breaths, and such to help you kind of organize some of these numbers and techniques. The rate is always 100, regardless of the age of the patient. Proper chest compression depth is defined as 1/3 of the anterior-posterior dimension in the infant, the child, and the adult. In the infant, again, that turns out to be about 1.5 inches, in the child about 2 inches, and an adult at least 2 inches. A summary of the ratios. Again, when you're by yourself, it's always 30 to 2. When you're working on an adult, it's always 30 to 2. In the case where you're doing 2 rescuer on an infant or a child, the proper ratio is 15 to 2. And then finally, rescue breaths. When compressions are not being performed, the proper rate per minute and the proper number of seconds between breath is shown in the chart. In the presentation that we'll distribute, you'll also find links, and these are live links if you'll click on those, for the summary of the American Heart 2010 guidelines if you want to read more about this, for a very nice set of videos, YouTube videos from a private company that did an excellent job with these videos, and there are videos on adults, children, and infants for choking, 1 rescuer, 2 rescuer, all the various combinations, and it's an excellent resource. And then if you can't remember staying alive, here's a chance to view that also.